Many young doctors who are just starting out with nerve blocks often feel frustrated, because their blocks don't seem to work as well or succeed as often as those done by more experienced colleagues. So today, I'd like to share a few tips that might help you with that. Today, I'll be talking about two main questions. First, why can't I get the needle in the right place, even though I'm doing exactly what I was told? And second, why does the block feel different in its effect, even though I thought I did it the same way? First, let's talk about the problem of not being able to get the needle where you want it. I'll go over 3 key points to keep in mind. The first point is this. When you think you're advancing the needle straight ahead, it actually tends to drift inward, toward the midline. Think about when you're holding a fork and knife. Are the tips pointing perfectly straight forward? Or do they naturally angle a bit toward the center? Because of the way our bodies are structured, the same thing happens with the needle. Even if you believe you're holding it straight, without realizing it, the tip tends to move inward, outside of your ultrasound view. And there's more. The ultrasound probe, which you think you've kept parallel to the needle, is being held with your other hand. That means it tends to rotate in the opposite direction. So, while you're focused elsewhere, the needle and the probe slowly end up in what's called a skewed position. The good news is, this is just a kind of habit. Once you become aware of it, you can correct it more and more easily. The second point is about the orientation of the needle tip. When you insert needles in daily practice, how do you usually face the bevel? Have you ever really thought about it? Take a look at the middle diagram. It shows the difference between turning the bevel toward the probe and turning it away. Here's the key: the shaft of the needle completely reflects the ultrasound beam. So what you actually see is only the front surface of the shaft. It feels like you can see the back as well, but that's just an artifact, multiple reflections. Now, when the bevel is facing upward, the very tip of the needle acts differently. It reflects the beam from the back side of the shaft. That's why, as you can see in the left diagram, the image shows a bright, step-like appearance, almost like a staircase. On the other hand, with any other bevel orientation, all you see is a straight line, like in the right diagram. And here's the problem: in that case, you can't really tell whether you're just seeing part of a skewed needle, or if you're actually following the tip all the way. That's why, to reliably identify the needle tip, you need to create this so-called double floor sign. The last point is about the puncture site. Now, is it always better to insert the needle as close to the target as possible? Intuitively, many young doctors tend to think so, and often choose the nearest spot. But actually, there are pros and cons. If you puncture from point A, close to the probe, the distance you have to advance the needle is shorter. But the angle becomes much steeper. Compare that to point B. From there, the distance is longer, but the angle is much shallower, and the needle approaches almost parallel to the probe. And here's the important part: when the needle is parallel to the probe, reflection improves and visibility is much higher. But once the angle exceeds 45 degrees, even the best designed needle will practically disappear from the ultrasound image. And if you can't see the needle, ultrasound-guided puncture is impossible. So, it's pretty clear which option is the better one, right? So far, we've talked a bit about how to handle the needle. Now, let's move on to the next topic: image optimization and puncture technique. Have you ever felt like this? You're using the same probe, at what you believe is the same position, and yet, the image looks completely different. That's what I'd like to talk about next. First, let's talk about how to create a good image. What exactly are senior doctors doing with the very same probe? In reality, it's nothing more than applying the basics. But the key is, they've mastered those basics, and that makes all the difference. Here are 3 especially important parts of the technique. P for pressure, improving image depth by adjusting probe pressure. T for tilt, improving perpendicularity by changing the angle. And A for alignment, optimizing image construction by keeping structures in line. Let's take a look at some examples. Take a look at this image. Can you clearly identify the nerve here? Most of you probably can't, and that's expected. And even if you think you can, you really shouldn't try to puncture a target that isn't well visualized. But here's the point, simply applying a bit of pressure with the probe, changing the muscle layers and the depth, can dramatically improve the image. And suddenly, the sciatic nerve comes into view. The next two examples are about alignment. Take a look at this image. Between the muscle layers, you don't really see anything, right? But when you adjust the alignment and direct the beam differently, suddenly the deeper nerve becomes visible. What was hidden before was simply masked by the lateral shadow coming off the facial boundary. Now, in this image, can you clearly see the boundary between the muscle layers? For someone with experience, this image might be good enough. But honestly, most of you probably wouldn't feel confident tracing that line with your finger. By adjusting the alignment, though, the view changes. And you can clearly see the bright facial structure between the nerve roots. I've shown a few sample images here. The point is, by creating a solid image before you puncture, the actual procedure becomes much easier. Have you ever had this experience? You're struggling with the puncture, so a senior doctor takes over, and suddenly, the technique looks completely different. Or maybe you studied the textbook approach, only to find that, in practice, your supervisor switches to something else entirely. The truth is, in the field of ultrasound-guided nerve blocks, many of the classic approaches you see in textbooks are neither safe nor reliable. They're simply old and outdated. Since those textbooks were written, we've had new guidelines, new techniques, and reports of more effective blocks published. And those updates often make a huge difference. For example, have you heard of the stay away technique? It's designed to reduce the risk of nerve injury during blocks. Traditionally, nerve blocks were taught with the goal of advancing the needle right up next to the nerve. But here's the problem, if you keep aiming so close, you'll eventually hit the nerve, and that's how injuries happen. The idea behind the stay away technique is simple. If you deliver the local anesthetic from a safer distance, away from the nerve, you avoid injuring it. By injecting into the compartment where the nerve lies, or even just into the adjacent compartment, you can still achieve effective analgesia while keeping the procedure much safer. Let's take the lateral femoral cutaneous nerve block as an example. Classically, the injection site was taught as 1 cm medial and 1 cm caudal to the anterior superior iliac spine. With ultrasound, you'd also start scanning there, trying to spot the bright nerve and inject around it. But here's the issue, not only is this approach cumbersome, it's also unreliable. That's because the lateral femoral cutaneous nerve can take 3 very different courses. It may pass over the inguinal ligament, under the ligament, or even through the iliac bone. The more reliable and now well-established method is different. You simply identify the fat plane between the sartorius muscle and the tensor fasciae lati muscle, just beneath the iliac crest, and inject local anesthetic into that space. This technique is quick, safe, and highly consistent, making it far more practical in everyday practice. Now, let's look at the interscalene block. Many people feel uneasy about advancing the needle right between the nerve roots. But here's the question, do we really need to? In fact, studies have shown that simply injecting into the middle scalene muscle, just a little away from the interscalene groove, can provide the same effectiveness. For a single-shot block, this approach is more than enough. The same goes for the axillary brachial plexus block. If you look at many textbooks, they still describe injecting local anesthetic separately around 3 nerves near the artery, plus another injection for the musculocutaneous nerve between the muscle layers. But in reality, none of that is necessary. All you need to do is advance the needle tip just beneath the artery and inject in a periarterial pattern. The local anesthetic will spread around the nerves in the axilla from there. And about the musculocutaneous nerve, just a little more proximally, it actually rejoins the same lateral cord as the median nerve. That means there's no need to block it separately in the first place. The only time you'd consider directing the needle toward an individual nerve is after your injection, if you notice inadequate spread. Finally, let's look at the obturator nerve block. The well-known approach is to scan just below the inguinal ligament, identify the 3 layers of the adductor muscles, and then inject separately around the anterior and posterior branches of the nerve. This method has become almost too famous. But here's the problem, it's quite unreliable, and there's a high chance you'll miss some of the branches. A better option is the proximal approach, the obturator canal block. Here, you inject local anesthetic at the external obturator foramen. It's simpler, more consistent, and does not even require nerve stimulation. The history of nerve blocks has always been about one thing: trying to place the needle as close to the nerve as possible, while still keeping it safe. But from the perspective of human error, that approach can never truly eliminate complications. Modern nerve blocks are moving in a different direction. We don't even try to get close to the danger zone, that is, right next to the nerve. Instead, we focus on 2 things. First, making sure the needle itself stays at a safe distance. And second, making sure the local anesthetic still reaches the nerve. Ultrasound imaging is what allows us to confirm both, and this is where the future of nerve blocks is heading. Now, let's look at one final point, from a slightly different perspective. It's about the concentration of local anesthetic, and how this differs between beginners and experienced doctors. Even with a single-shot block, the concentration is often adjusted depending on the type of surgery and the patient's condition. For example, if the block is combined with general anesthesia, is there really any need to use a high concentration of local anesthetic? Of course not, that's completely pointless. After all, producing immobility is the job of general anesthesia. On the other hand, if you use too low a concentration for a procedure under sedation or while the patient is awake, you may leave skin sensation intact, which causes discomfort. Or the limb may move during surgery, disturbing the surgeon. So this is where experience really matters, adjusting the concentration to match the patient's age, their condition, and the purpose of the block. So, does concentration really make that much of a difference? Interestingly, the duration of analgesia does not depend on the concentration. But the onset time and the likelihood of motor weakness change quite a lot. This figure shows the results with a brachial plexus block. On the left, you can see sensory block. With a higher concentration, the onset is faster. But in the end, even with 0.25%, the block still reaches the same level. On the right, you see motor weakness. With higher concentrations, patients eventually lose strength completely. But with lower concentrations, some patients never reach full motor paralysis. Of course, the exact difference depends on which block you're performing. But the principle is clear: high concentration and low concentration behave differently in these ways. So, especially for nerve blocks combined with general anesthesia, the rule should be low concentration, high volume. So, we've gone through a lot of lessons today. But let's be honest, just knowing all of this doesn't mean you'll suddenly be able to perform perfect blocks in every single surgery tomorrow. So, what should you actually do? And this is where learning the right forms or patterns becomes important. For each surgery, there's a block that works best, and that's what you should aim to master. The goal is to control the strong pain with the block, but not to eliminate every single sensation with it. We also have to think about motor weakness and how it can affect a patient's daily activities. That's why our mindset should be one of multimodal analgesia, combining different strategies to provide safe and effective pain control. For example, let's take total knee replacement. We might use a femoral nerve block or a saphenous nerve block to cover the main source of pain. But for the tibial side, the sciatic territory, we don't perform a sciatic nerve block, because the resulting motor weakness can linger. Instead, we manage that part of the pain with an intra-articular cocktail. Since the effect of the cocktail only lasts about 6 hours, opioids are often appropriate afterward to bridge the gap. This kind of combined, rational approach to analgesia is what's recommended. So let's always aim for pain control that makes sense, through the right combinations. The kind of analgesic strategies I've shown today are also richly presented in Prospect, which provides evidence-based, multimodal analgesia recommendations for each surgical procedure in the form of clear infographics. Of course, you don't need to follow them 100% of the time. But the important thing is to adapt them to the realities of your own institution, while still striving to optimize pain management. And for that reason, I encourage you to keep learning and mastering nerve blocks, so you can contribute to this goal. Keep practicing, keep learning. And nerve blocks will become your strong ally. Thank you for watching.